have the adrenal cortex that we're going to talk about. And there are 3 things that I want you to write at the top of the page. Number 1 is not enough steroids, okay? Number 1 is not enough steroids. Number 2 is shock. And number 3 is high potassium. So the 3 things that you've got written down there are not enough steroids, shock, and high potassium. So we see that Addison's disease is an adrenocortical insufficiency. We're going to look at the pathophysiology. If the client is insufficient, do they have enough glucocorticoids, mineralocorticoids, or sex hormones? No. That's why at the top of the page we wrote not enough steroids. So for the next few questions that we're going to talk about, we're focusing on aldosterone. Now normally aldosterone makes us retain sodium and water and lose potassium. We all agree on that, okay? Now we don't have enough. We are insufficient here. So we're going to lose sodium and water, and we're going to retain our potassium. So my serum potassium is going to be high. Now, when we look at the signs and symptoms here, the majority of those signs and symptoms initially will come from hyperkalemia. And we learned in our fluid and electrolytes that hyperkalemia begins with muscle twitching and then proceeds to muscle weakness and then flaccid paralysis. Other signs and symptoms that we have: anorexia, nausea, hyperpigmentation, decreased bowel sounds, GI upset, white patchy area of depigmented skin. We also call that vitiligo. And hypotension because of them losing the sodium and water. So your lab values are going to show a decreased sodium, increased potassium, and hypoglycemia. Let's look at our treatment here. We have to combat shock. So we got to fight the shock. Why do we have to fight the shock? Well, we're losing what? Sodium and water. So we're losing volume. So to get those Addison's questions right, you've got to know that they are losing sodium and water. Okay? So with this client, this is the one client that it is okay to actually increase their sodium in their diet. So it's okay for this person to have that processed fruit juice, that broth, because those things have a lot of sodium in them. I know in daily weight, that is very appropriate because this is a fluid problem, right? Right. So if this person is losing sodium and water, their blood pressure is probably going to be low. They're probably going to be doing what? Gaining or losing their weight? They're going to be losing their weight. So with this, you got to think the major nursing diagnosis is going to be fluid volume deficit. Fluid volume deficit. This person is going to be placed on a mineralocorticoid, aldosterone, or Florinef. That's what they need, right? They need to replace that aldosterone. And we know daily weights are very important when they're adjusting their meds. So let's think about that for just a second. Let's say I have a big bowl of Florinef pills and I paint them to look like M&Ms. Well, you come up and you get a handful and you start eating them. If you start eating those, you're going to start retaining what? Sodium and water, right? So when you start retaining that sodium and water, naturally your weight is going to go up, okay? Your fluid volume is going to go up. So they have to weigh themselves every day. Now, look at your rule that we have right there. When you have someone who is weighing themselves every day, what we're trying to do is to keep their weight within 2 to 3 pounds plus or minus of what their normal is. We've already talked about that when you start retaining fluids or any acute weight gain, you need to worry about what kind of problems. Remember, we talked about heart problems. Going to be worried about heart problems. So a good NCLEX tip for you to remember, guys, is when you have fluid retention, you better be thinking heart problems first. You better be worried about pulmonary edema, okay? So back to our client who is on the Florinef. Let's look at our little critical thinking exercise that we have right here. Let's say you have a client at home that's taken that Florinef, and the following occurs. What should the client do? So we see that the client has gained 7 pounds in one night. Way too much fluid, right? Way too much fluid. So what are we going to need to do to their morning dose that they take? They either need to decrease it or they hold it. So write both of those answers down, okay? Decrease or hold. And you're like, well, come on, Annette, which one is it? Well, you're not going to have to pick one on boards, okay? But the client has learned how to adjust their medicines based on their weight, which reminds me of some other patient that I can think about that has to monitor something, and that is my diabetic patient. They learn how to manipulate and adjust their insulin based on their blood glucose levels, right? Okay, so these patients know what to do with their medicines according to how much weight they gain. But let's say in another situation that they have lost 7 pounds overnight. Way too much fluid loss, right? Way too much. When you have lost that much volume overnight, what is my heart going to start doing? It's going to start beating really fast because it's going to try to compensate. Could this client actually go into shock? Yes, my client could go into shock. That's what I'm scared of. So what needs to be done with their morning dose? They need to increase it, okay? They need to increase it. We want them holding on to that sodium and water here. Now, we see here, let's say you're taking care of a client in the hospital on floor F, and they develop edema, and their blood pressure goes up. That's fluid retention, right? Right, especially if they're on floor F. So what needs to be done with their morning dose? We're going to hold it, and we're going to call who? Call the doctor, right? Call the doctor. Because if you give it to them, they're just going to be retaining more volume. Now, ask your friend what's going to happen in the next critical thinking exercise that you see there. You see, if you have somebody whose blood pressure is steadily going down, I bet the doctor's going to come in and do what to their dose? Going to increase their dose. I want to emphasize something here. If clients are on steroids, are they on the same dose of steroids for the rest of their life? No. We know that those dosages are always doing what? They're always changing. They're always changing. And your teachers taught you to never stop taking those steroids abruptly, right? They have to be tapered off, okay? Because if I'm taking a steroid, what happens to my adrenal glands? What do those adrenal glands do? They go to sleep, right? They go to sleep. Well, if you stop taking your steroid all of a sudden, are you going to have any steroids in your body? No, you're not. And anytime you don't have any steroids in your body, what disease do you get, guys? We call it Addisonian crisis, right? Addisonian crisis. And we see in an Addisonian crisis, your client will have severe hypotension and vascular collapse. So in an Addisonian crisis, same thing as Addison's disease, but it's 100 times worse, and it's definitely more acute. Now, I want you to see if you can take something that you've already learned. And here's a question I'm going to ask you. In Addison's disease, what is going to happen to your blood sugar? Talk to your friend about it. You know, earlier when we were talking about steroids, we said steroids make your blood sugar do what? They go up, right? But in an Addison's disease, I don't have any steroids. So my blood sugar is going to go down. So see here, I could write you a hypoglycemia question in a patient that has Addison's disease. All right, now we've made it to Cushing's. Let's look at Cushing's. At the top of the page here, I want you to write too many steroids. Okay, too many steroids. And the minute you heard the word Cushing's, you automatically thought about that naked man in your med-surg book, didn't you, right? He had the moon face, buffalo hump, skinny arms and legs, large belly. Okay, we all know what this person is going to look like. And we see here that under those signs and symptoms that these people have too many glucocorticoids, mineralocorticoids, and those sex hormones. So in other words, I have too many steroids. That's why at the top of the page we wrote what? Too many steroids. Now, if you notice on your page there, we have 3 clusters of symptoms. One is because you have too many glucocorticoids, and one of them is because you have too many mineralocorticoids, and the other one is because you have too many sex hormones. But see if you and your friend can look at those clusters of symptoms and see if you can figure out which ones go with which. And you may have to flip back and forth in your pages there and see, get some hints there. All right, so let's look at that first group right there. What do you think about that first group? Glucocorticoids, right? That's right, glucocorticoids. What about the second group? Sex hormones, right? Those sex hormones. And what about the third group that we see right there? Those mineralocorticoids or aldosterone. So now that I know they have too much aldosterone, we know that their nursing diagnosis is going to be fluid volume excess. Fluid volume excess. Because we know aldosterone makes you do what? Retain sodium and water. Okay, so you see the next sentence right there says, since the client has too much mineralocorticoid or aldosterone, serum potassium is going to be low. That's right, it's going to be low because we're holding on to sodium and water, but we're doing what to that potassium? We're losing that potassium. So see, here I could write you a question about hypokalemia. All right, if you do a 24-hour urine on this client, is the cortisol level going to be high or low? It's going to be high, right? Because cortisol, we know, is just a fancy word for steroids. Treatment, adrenalectomy, maybe unilateral, maybe bilateral, and we see if both adrenals are removed, you may need a lifetime replacement. Because can you live without your steroids? No, you just can't do it. You'll see here that this client needs a quiet environment. Well, when your steroids are messed up, guys, you just can't handle stress, okay? When your steroids are messed up, you just can't handle stress. What does this client need in their diet pre-treatment? See if you and your friend can fill in those blanks under there. All right, what about their potassium? We need to increase it, right? We're going to increase their potassium because they're losing it. Remember, they're losing it. What about that sodium? What are we going to do to it? Decrease it, right? Decrease it because they're retaining that sodium and water. What about protein? We're going to increase it, right? Increase it because they're breaking it down. Calcium, increase it. Because remember, we said steroids do what to that serum calcium? They decrease that serum calcium. And today we're adding another little sentence there. Steroids decrease serum calcium by excreting it through the GI tract. So let's think about that for just a second. Every time I take a steroid, my serum calcium is going to go down. It's going to go down. Well, my body tries to fix it, okay? So I start pulling that calcium from my bones and putting it into my blood. Well, tomorrow I take my prednisone, which is a steroid, right? So my calcium level decreases it. My body tries to fix it. It's like, where'd that calcium go? So it goes to my bones, pulls it, and puts it into my blood. So my point is this. When you're on steroids, what kind of bones are those patients going to have? They're going to have very brittle bones. Steroids, we know, can cause you to have osteoporosis. It's just a fact, okay? It's going to happen. Like, let me give you an example. You have a client who has been on steroids long term, and they code. You go in there and you're doing CPR on them. What's going to happen? You're going to actually break some ribs. What about little granny who has rheumatoid arthritis and she's been on those steroids and she sneezes? She could actually break a rib. Or even turning a client in the bed who's been on steroids for a long time. Now, we also know that steroids suppress your immune system, so you better avoid those exposure to infections. And what might appear in their urine? Ask your friend what you might see in their urine. Now, the top three answers that we usually get are protein, glucose, and ketones. Okay, so write that down. Protein, glucose, and ketones. So you got three things written down. Out of those three options, which one's wrong? Because one of them is wrong. It's going to be protein, right? Protein. And you're like, well, Annette, why'd you make me write it down? Well, I wanted you to write it down so you'll remember it. So now put a big old X over protein, all right? Now, how big is a protein molecule? It is like this big. It is huge, okay? And a protein molecule can't go through your glomerulus unless you have glomerular damage. Now, have I said the word glomerular since we've been talking about all this? No. So this person does not have glomerular damage, so you're not going to have proteinuria. You're not going to see that protein in their urine. Sounds right because you're breaking down that protein, but guess what? It's wrong, okay? It's wrong. Now, we know that glucose is right because steroids, we already said, make our blood sugars go up. And your teachers told you when your patient's blood sugar goes up, that excess blood sugar is going to spill over into the patient's urine, okay? And ketones we know are right because the client is breaking down body fat. They're breaking down body fat. So glucose and ketones, those are going to be my two answers. Now, let's move on to diabetes. Now, with diabetes, let's talk about type 1, insulin dependent. They have very little or no insulin, okay? Usually starts in childhood. First sign may be DKA. So we see that it appears abruptly despite years of beta cell destruction. Let's look at the pathophysiology because if you don't understand this, you're not going to understand anything about diabetes. So it says on your handout, let's read it together. You have to have insulin to carry glucose out of the vascular space over to the cell. We all agree on that, right? Right. Well, since there is no insulin, the glucose builds up in my vascular space. The blood becomes hypertonic and pulls fluid into my vascular space. Well, the kidneys filter the excess glucose and fluids. Now we see polyuria. The cells are starving, so they start breaking down protein and fat for energy, so now we see polyphagia. Okay, when you break down fats, you get what? Ketones. Okay, ketones are acid. So now my client is acidotic. Well, which one is it? Respiratory or metabolic? It is metabolic acidosis. All right, let's talk about it. Who's going to compensate? My lungs, right? My lungs are going to compensate. They compensate with what chemical? CO2. CO2 is acid. Well, if I'm already acidotic, do I want to keep my CO2 or do I want to blow it off? I obviously want to blow it off. So now my respiratory rate has to go up, and since I'm a diabetic, the name of those respirations are Kussmaul respirations, right? So my patient starts Kussmauling. Now, there are a lot of signs and symptoms, and we can see right there in your book it says hyperglycemia, the 3 Ps, polyuria, polydipsia, polyphagia. Well, let's talk about polyuria first. When we were talking about fluid and electrolytes, we said with polyuria, think shock first, right? We said when you're a diabetic patient, your vascular space is filled with what particle? Sugar, right? It's filled with sugar. And anytime you get too many particles in your blood, you're going to have PID, right? Tell your friend what PID stands for. Particle-induced diuresis, right? We said it's not pelvic inflammatory disease, but it's particle-induced diuresis. So my kidneys are trying to help me get rid of some of that sugar. But we said yesterday, can you just excrete a big old sugar particle? No. It's got to come out in volume. So anytime you have polyuria, you're going to be losing volume. And we know that that can lead to shock. Now, polydipsia is excessive thirst. You're losing lots of volume. You're going to be thirsty, right? Yes, you're going to be thirsty. Polyphagia, we know that that is excessive hunger. Well, the cells in my body are hungry. But if I eat more, is it going to do me any good? No, because I still don't have any insulin to carry the glucose where? Back into the cell or into the cell. Now let's look at our treatment. Will oral hypoglycemic agents work for this client? No. They have to have what? They've got to have insulin. All right, now let's look at type 2 diabetes. We call this non-insulin dependent diabetes, NIDDM. Let's look at our pathophysiology there. These clients do not have enough insulin, or the insulin that they have is no good. So with this person, is their pancreas still working? Yeah, it's still working a little bit. See, these clients have just enough insulin to keep them breaking down fat for energy. So we're not going to see metabolic acidosis with type 2 diabetes. This is one of the big differences between type 1 and type 2. Type 1 has very little or no insulin, and type 2 just doesn't have enough, okay? As we see, these clients are usually overweight. They can't make enough insulin to keep up with the glucose load that the client's taking in. So this type of diabetes is not as abrupt as type 1. You know, type 1 diabetes, that's pretty abrupt when you wake up in the emergency room and DKA and metabolic acidosis, right? Type 2, this is a little sneaky one. This is one that we see is usually found by accident. Or maybe the client keeps going back to the doctor for things like a wound that won't heal or those repeated vaginal infections. Now, why does this person have such a hard time with those infections and those wounds not healing? Because they have a lot of what in their blood? They've got a lot of glucose, and we know that bacteria thrive in that kind of environment. They love it. All right, individuals with type 2 diabetes should be evaluated for what kind of syndrome? It's metabolic syndrome, or we call it syndrome X sometimes. And this includes insulin resistance, obesity, increased triglycerides, decreased HDL, increased blood pressure, and CAD, coronary artery disease. Let's look at our treatment here. Diet and exercise. We know that in some clients, that fixes it. They just need a little bit of control. Some people we have to add oral agents. And then some people have to take insulin to control their blood sugar, especially if they are non-compliant. All right, now we're going to talk about gestational diabetes. Now this resembles type 2. During pregnancy, the mom needs 2 to 3 times more what? Insulin, okay? So they screen the mom at 24 to 28 weeks of gestation if she's older than 25 or earlier if they have a family history of diabetes. Some complications to the baby are increased birth weight and hypoglycemia. Now, let's look at general treatment for any kind of diabetes. And the first thing we're going to look at is their diet. And we'll see with their diet that the majority of the calories should come first from those complex carbs, then fat, and then last is going to be their protein. So the most important point we want to think about when we're looking at diet is we're trying to limit that protein, okay, to about 10 to 20% of the diet. Because we see diabetics tend to have what kind of disease? Renal disease, right. And when you have renal disease, you just can't handle that protein. That's right. So why are those diabetics prone to coronary artery disease? Because sugar deposits and destroys those vessels just like fat. okay? Sugar deposits and destroys those vessels just like fat. Everybody in here understands what happens to your vessels when you eat a really high-fat diet. Well, sugar does the exact same thing, okay? So that's why we need to keep their sugar normal, because it's just destroying those vessels. All right, we see that a high-fiber diet is great for this person because it helps keep that blood sugar steady, and they may have to decrease their insulin if they actually stick to the diet. So we see that high fiber slows down glucose absorption in the intestines. Therefore, it eliminates that sharp rise and fall in their blood sugar. So for most people, if they take a break and they eat 3 donuts, what's going to happen to their blood sugar? It's going to shoot it up, and then it's going to bottom it out. So extremes in that blood sugar equals vascular damage. Again, it's those extremes in that blood sugar that is going to equal vascular damage. That's why that high fiber diet is so good, because it keeps that blood sugar steady. Okay, keeps that blood sugar steady, and that's what we want. We don't want those extremes in their blood sugar. All right, exercise. They need to wait until their blood sugar normalizes until they begin their exercise. So they got to wait till that blood sugar normalizes, then begin their exercise. And what should they do pre-exercise to prevent hypoglycemia? They need to eat something. That's right, they need to eat something. Now, when should they exercise? When their blood sugar is at its highest or when their blood sugar is at its lowest? When it's at its highest, right? It's just not very smart to go out running with your low blood sugar, because where are you going to end up? In the ditch, and you're not going to be burning any calories doing that, okay? All right, now, with their exercise, they need to do it at the same time and amount every day. So the same time and amount daily. We're trying to establish a routine. Guys, routine is very important in our patients who are diabetic. Routine is very important in our diabetic patients. Now, let's look at their medication. How do oral hypoglycemics work? They're going to stimulate that pancreas to make insulin. You'll see on your handout it says that not all oral hypoglycemic agents stimulate the pancreas to make insulin. But the safest answer for NCLEX is that oral hypoglycemic agents will stimulate my pancreas to make insulin. And you'll see several hypoglycemic agents that listed there for you. And don't forget that we have a pharmacology folder on that 5th day material that we want you to study, okay? It's going to include the medications that we're talking about with these lectures and the information that you'll need to know for that brand new nurse. Now, back to type 2. You can only give these to a type 2 diabetic, because you can stimulate a type 1 pancreas all day long, but is it going to make any more insulin? No, it's not. All right, so next we're going to look at insulin. How is their insulin dose determined? It's going to be increased until the blood sugar is normal and there is no more glucose or ketones in the urine. Because if I have glucose in the urine, then I know my blood sugar is too high. They need more insulin. And if you have ketones in their urine, then you know that they're breaking down fat. And that's very dangerous because it could lead to metabolic acidosis. All right, we see that regular insulin is clear and NPH is cloudy. All right, Lantus is also clear and is considered a long-acting insulin. And we know it cannot be mixed with any other insulin. Now, which one is the one that we can give? It's actually the only one that we can give IV. Regular. That's right, regular insulin. Now, when you're drawing up regular and you're drawing up NPH insulins, which one are you going to draw up first? You're going to draw up the regular. That's right, you got it. Now, let's look at hemoglobin A1C. That's a blood test, and it gives an average of what their blood sugar has been over the past 3 months. You know, this is how you can tell if your patient's been telling the truth about how well they've been controlling that blood sugar the past 3 months. All right, now we see that clients should eat when insulin is at its peak. That's right, when insulin is at its peak. That's why you had to memorize all of those peaks of insulin. Because when insulin is at its peak, that means my blood sugar is going to be at its lowest. Now, we always need to monitor that client that's on insulin for hypoglycemia, okay? We talk a lot about peak times because it is the most concern, but onset through duration of our insulins is important also. All right, what's going to happen to your blood sugar when you get sick or stressed? It's going to increase. It's going to increase. And we know that the normal pancreas can handle those fluctuations. An increase in blood sugar when they're sick or stressed is a normal reaction to help fight that stress or that illness. So if I'm a diabetic, what might I have to do to my insulin dose when I'm sick? Increase the dose. Now, if I don't increase the dose when I'm sick, what is the major complication I'm headed for? DKA. So, I want you to write this down. Illness equals DKA. That's a good NCLEX tip, okay? Illness equals DKA. All right, let's talk about rotating sites with insulin. We need to rotate within an area first, okay? But that's not what you see when you're in the hospital. You see nurses, they'll go in the room and they'll ask the patient, where'd you get that last shot? And the client will say, okay, I got it in here. And the nurse is like, well, if you got it in your right arm, let's give it in your left arm this time, okay? Okay. Well, that's not what they're supposed to do. You don't just randomly give shots, you know. If you're randomly giving them the shots, then their tissue is not going to have time to heal, and that's what we need. So you teach them this week, you need to use up all the sites in your right arm first. And then don't use that right arm for like 3 to 6 weeks so it can heal. Because if you don't let it heal, it's going to get that scar tissue, that connective tissue, that lipodystrophy that they get, and then they're not going to be able to absorb that insulin very well. And that is not good because we need that absorption of that insulin. Do they aspirate when they give their insulin? No. No. And the reason we don't aspirate is because it causes too much tissue trauma. Aspiration is going to cause too much tissue trauma. What other drugs do we give that we're not supposed to aspirate with? Heparin and Lovenox, right? And it's for the exact same reason. Now, we see that insulin infusion pumps, that's the next thing we're going to mention. It is an alternative to those daily insulin injections that they can get. And we see that most clients are able to obtain better glycemic control because they are receiving a basal level of insulin from the pump and can take additional insulin as needed with their meals and if they have an elevated blood sugar. All right, let's talk about our signs and symptoms of hypoglycemia. I want you and your friend to write down as many signs and symptoms of hypoglycemia as you can. You know what they are, right? Cold and clammy, confused, shaky, they have a headache, they're nervous, they get nauseated, their pulse rate increases. So, if I'm hypoglycemic, what do I need to do? Eat a simple sugar, right? You need to eat something to get that blood sugar up really fast. That is the key. Drink a Coke, eat some candy. Now, not a lot, okay? Just a few ounces or maybe just a small piece of candy. Something to get that blood sugar up really fast. You know, even milk will help get your blood sugar up fast. Now, when that blood sugar does come up, what do you need to do? Eat some more, right? But now they need to eat complex carbs and protein, like peanut butter and crackers. Like if they just drank a Coke and they don't follow it up with some complex carbs and some proteins, what's going to happen? That blood sugar is just going to do what? Boom, it's going to bottom out again. And every time a client's blood sugar bottoms out, they're going to lose some brain cells. And that's what we want to prevent, okay? So anytime someone is hypoglycemic, you better worry about their brain. Let's say you go into your diabetic's room and they are unconscious. Do you treat them like they are hyper or hypo? hypo, right? Because I'm worried about the brain. But can they be unconscious with both? Yeah, they can be unconscious with hypo or hyper, but hypo is more scary, right? So we're going to pretend that the patient is hypo. All right, if that happens, we're going to run to the drug cart. We're going to get an amp of D50 and push it IV and hope that they wake up. So when the patient does wake up, what do they need to do? They need to eat something so it doesn't bottom out again. We know that injectable glucagon, we know that's an IM shot that you can see given every once in a while. You may have to use it if they don't have any IV access, but D50 is my favorite because it's IV push. All right, to prevent this from happening, they need to do what? They need to eat, they need to take their insulin regularly, and eat those snacks. So eat, take their insulin regularly, and eat those snacks. Y'all know what I'm talking about with those snacks, right? You've been working at the hospital. You know they bring those cute little snacks up to the floor like at 10 o'clock in the morning and 2 o'clock in the afternoon and 10 o'clock at night. Well, who's supposed to get them? The patient, right? The patient is supposed to get them. Don't say, oh, you know, Papa, he's asleep. I don't want to wake him up. Maybe I'll eat this later. I'm a little hungry. No, you go wake Papa up and you make him eat a snack. He's the one that needs it. All right, let's look at our next critical thinking exercise that we have there. If Papa is diabetic, he's at home and he comes to the kitchen and all of a sudden he gets cold and clammy and he falls on the floor. What is Mama supposed to do? Ask your friend. She knows he's hypoglycemic. What is she going to do? Did your friend say, go get some of that cake decorating gel? She's supposed to keep that at the house, but sometimes they don't because it can be expensive. So get some jelly, get some honey, get some syrup, put it under the tongue, but don't too much, not a whole lot, because you don't want them aspirating on some grape jelly, okay? Now, she's going to cross her fingers, and she's going to wait for him to do what? Hopefully he's going to wake up, right? And when Papa wakes up, what should he do? He needs to eat, right? Eat some of those complex carbs and protein, like those peanut butter and crackers. That would be good. All right, moving on. Let's look at these complications of diabetes. All right, with these complications, we're going to talk about DKA. Let's look at the pathophysiology that we have right there. Anything that increases my blood sugar can throw my client into DKA. The number one thing I think about here is illness. So put a big star by that word in your book. I'm thinking about illness. Also, infection or missing a dose of insulin can throw you into DKA. DKA may be the first sign that they have of diabetes. Other signs and symptoms are the same that you see with our type 1 diabetic. Now, read that pathophysiology to yourself. Got it? Okay, same thing all over again. Y'all, in DKA, you have very little insulin or no insulin and severe hyperglycemia, which leads to fat breakdown and then metabolic acidosis. So, let's look at the treatment. With DKA, we've got to find the cause. What was the illness? Well, we got to treat the illness. You know, if you work in a place long enough, you'll have clients coming in over and over again that have experienced DKA by skipping their insulin. Well, if you start skipping your insulin, what's going to happen to your blood sugar? It's going to be really high. It's really high. So anytime your blood sugar gets really high, you're headed towards DKA. Okay, so you need to do hourly blood sugar and potassium levels on these patients. Because what are you going to be giving this client in their IV? You're going to be giving them some insulin in their IV. And we've already talked about when you give somebody IV insulin, 2 hypos can occur. What were those 2 hypos? Hypoglycemia and hypokalemia, right? We know that insulin decreases their blood sugar and potassium by driving them out of that vascular space and putting them into the cell. So you're going to be on the phone calling the doctor, giving him, hourly, you're going to be calling him, giving him those critical values for what their blood sugar and their potassium levels are. All right. Do we need to monitor the EKG? Yes, we need to monitor their EKG because what electrolyte are we messing with? Potassium. Could my client develop a life-threatening arrhythmia? Yes. You got to be doing hourly outputs because by the time the client comes in, they could have already done the polyuria thing, right? So by the time you get them, they could be to oliguria or even anuria. Even though we expect that to happen, guys, we're still going to worry about it because we want good kidney perfusion. We want good kidney perfusion. ABGs. Tell your friend which acid-base imbalance this client is going to be in. Metabolic acidosis, right? Metabolic acidosis. IV fluids, those are very important. Okay? Now out to the left of IV fluids, I want you to write polyuria causes shock. Polyuria causes shock. That's why on these patients, we're going to start with some normal saline, okay? Here's what they're going to do, guys. They're going to get 2 antecubital lines, 2 antecubital IVs, and they're going to be getting that saline as fast as they can because they're trying to replenish their volume. And the reason they're getting that normal saline is because normal saline is what classification of solution? It is an isotonic solution, right? And we know isotonic solutions go into that vascular space, they stay there, and they build up that volume, which is going to make my blood pressure come back up. That was good. That's what I needed. Now, it says on your handout that when that blood sugar gets down to about 300, we're going to switch one of those IVs to D5W because we are trying to keep from throwing that client into hypoglycemia. Because what are they still getting in that IV? They're still getting insulin. And that next dose of insulin could do what to my blood sugar? Drop it. Okay, it could drop it. And at some point in time, you're going to anticipate that the doctors are going to want to add what else to the IV. Ask your friend what they think. What's it going to add? Potassium, right, KCl. Because what is that insulin doing to that serum potassium? It is dropping it, dropping it. Okay, now we're going to talk about hyperosmolar hyperglycemic non-ketosis, which is HHNK, or hyperosmolar hyperglycemic non-ketosis coma, HHNC. That's why we just say HHNK. It looks like DKA, but with this there is no acidosis. HHNK is seen in our type 2 diabetics. This is when the client comes to the emergency room and everybody knows that they're diabetic and everybody's saying, yep, DKA, yep, I know it's DKA. I know it's DKA. Got DKA written all over it. Well, when they draw those ABGs on the client's not acidotic. So you can't be in DKA if you're not acidotic. So we'll see how this works. They're making just enough insulin that they're not breaking down that body fat. Well, if you're not breaking down body fat, you're not going to have any ketones. Don't have any ketones, no acids. Hey, are they going to have that fruity breath odor? No, they don't have ketones, so no fruity breath. So this patient must be what kind of diabetic? Type 2, right? Type 2. Because we said that type 2 makes a little bit of insulin, just a little bit of insulin. Are they going to have Kussmaul respirations? Nope. Nope. So in NCLEX world, type 1 gets DKA, type 2 gets HHNK. So type 1 gets DKA, type 2 gets HHNK. So if I had to pick out one complication that affects diabetics the most, it's going to be those vascular problems. All right. They will develop poor circulation everywhere due to that vessel damage. Now remember, the more controlled the diabetic is, the fewer complications that they're going to have. So I'm talking about worst case scenario here. And the type of vascular problems that they're going to have is going to be like diabetic retinopathy. And this can occur because your retina is very vascular. And that can lead to blindness, right? What about nephropathy? Are my kidneys vascular? Yes. That's why so many diabetics wind up on dialysis. All right, then the next thing we have is neuropathy. We know that that's nerve damage, which can lead to problems like, number one, sexual impotence, which is impotence. They can have decreased sensation. And impotence may be the very first thing that makes the client go to the doctor. And then they find out that they're diabetic. But do they already have the nerve damage? Yeah, they already have the nerve damage already. All right, then we see that they can have foot and leg problems. We're talking about pain, paresthesia, numbness here. So you'll hear clients with that peripheral vascular disease, and they may complain of their feet aching and burning, and they might even get into water that's just way too hot. Okay, they may burn themselves. Now, I want you to take just a few minutes and go over diabetic foot care and teach your friend all that they need to know about foot care. We know that those toenails have to be cut how? Straight across, straight across. If they're cut really short, they can start to grow in and have ingrown nails. Now, do they have to dry completely between those toes? Absolutely. Yes, they've got to dry completely between those toes, because what loves to live in warm, dark places? Bacteria. Do they have to wear shoes all the time? Yep, they got to wear shoes all the time, those well-fitting shoes. Girls, you know how we are. We find that pair of shoes that we're going to wear on Friday night, and it doesn't matter how tight they are, or even if it's the right size, we're going to get our foot in that shoe, because we can stand anything for just a couple of hours, right? Yeah, but can our diabetics do that? No, they can't do that. How often should they look at their feet? How often should they inspect their feet? Every day, every day. Well, what if they can't see the bottom of them? What are they going to do? That's right, they're going to get that mirror out, put it on the ground, or they're going to have a really good friend, because you got to have a really good friend to look at the bottom of your feet, right? All right, remember you can't use any harsh chemicals, so we don't want any betadine on their feet, so no harsh chemicals on their feet too. All right, then neurogenic bladder. That's when your bladder doesn't have any tone, so the bladder doesn't empty properly. The bladder may empty spontaneously. We call that incontinence. Or it may not empty at all, and that is going to be retention. And finally, gastroparesis. That's when the stomach is delayed in emptying, and we know that there's an increased risk for aspiration. All right, you know, diabetic clients are also at a high risk for infection. Okay, that's all for the endocrine.